Mike, I was going to just mention, it's an obvious point, but in your Hep B, the issue of making sure you don't stop the Hep B coverage in a patient. I mean, I think we've heard of cases of bad outcomes of stopping the tenofovir or FTC or whatever the other coverage are. I don't know if you want to comment on that.
Yeah, I think the danger is that there can be flares as the medicines are stopped, and those flares can be pretty intense. So once you start, you want to continue, especially for the hepatitis B component.
Great. I'm not going to encourage you to leave quite yet. I think we have another couple slides, if I'm not mistaken. Starting with this one. So, IAS-USA, as you heard today, has just come out with a new antiretroviral treatment guidelines, but we've done a pretty remarkable thing. I'm going to call out Donna Jacobson, who's the president and executive director of the organization, because in addition to taking on the CROI management, which we now do as an organization, and coming out with our ARV guidelines, and participating with the other organizations in the HCV guidelines, we've also just come out today in JAMA, also with the first ever broad prevention guidelines, including evidence reviews for biomedical prevention. So a pretty remarkable achievement for the organization, and one that would have been absolutely impossible without Donna's leadership. So I'm going to lead a round of applause for Donna. And she's the one, if you don't know, who's been coming up and back and forth and helping us with this, with the audiovisual challenge that we had, and the balance of us versus Bill Clinton, who I think is in the back joining our discussion. I hope, Bill, I hope you got a keypad. Good. We were given a few extra minutes by the organizers because of the delays in getting started. So. We usually are pretty cautious about letting audience say anything, because sometimes if we're on a really tight schedule, it can really slow things down. But if people have questions about anything, there are a couple microphones, front and back, and Trip Gulick is going to lead the pack. Trip is often up here on panel with us, so Trip, welcome.
Sure, thanks. I'd be interested in if the panel could comment on the novel combination of boosted darunavir plus dolutegravir. So there's been a lot of enthusiasm at this meeting and at this session for that combination. The data seem relatively limited, so I wanted to hear. We've been surprised before, and I'd like to hear what people have to say.
Maybe Joe or Joel?
Well, I'll start because I mentioned it as an option in the case we discussed where we needed a nuke-sparing regimen. And it was my choice if I had to use a nuke-sparing regimen, but I added lamivudine or emtricitabine, just because we continue to be surprised by these PI and integrase inhibitor regimens that seem like they should be really good, but there's always some kind of a flaw. And whether that's because they're lacking a reverse transcriptase inhibitor, I don't know. But so far, the best efficacy results with nuke sparing have been with a PI plus an RT inhibitor, either an NNRTI or an NRTI. And for that reason, I'm kind of extrapolating by throwing in the lamivudine or emtricitabine.
Yeah, I would be extremely cautious. I don't think we really understand why two drugs like darunavir, ritonavir, and raltegravir weren't perfect. And they were far from perfect in the NEAT trial. The NEAT trial obviously achieved its primary endpoint, but as I think Peter pointed out, in the high viral load and especially low CD4 group, there really was a difference. And I'm with you, Trip. I would be very careful about doing something like that without a study to support it.
And we saw those challenging results from Modern yesterday too, where there was an interaction that didn't seem to make sense. Great.
Yes.
There's a question.
Oh yes, go ahead.
Thank you very much. I'm Joe Makhaman from Botswana. I think this is very, very wonderful to come out here and to hear state-of-the-art antiretroviral therapy and get to have all these different drugs that you do have. And very often in the developing countries, we don't have all these alternatives. And I think that to a certain extent, we should actually have guidelines streamlined to the developing countries. Also, I suppose, presented in parallel with what you may have in an optimized environment, so that we can also take to our countries, based on what we can afford, the best that we can.
Thank you for the comment, and I would... When you read the guidelines, we explain that we do understand the many challenges in access, that the guidelines that we're discussing really are meant for places with relatively few limitations in access. I would think going forward, the combination of these guidelines approach and some of the other ones from resource-rich settings, combined with the WHO guidelines, which are much more kind of, to your point, I think, are a good way to do that. Maybe as a future activity, maybe having a discussion about some of these things so that this could be all be addressed openly. So, Pedro.
Yeah, I would like to follow on Paul's comment. First, we have the WHO guidelines as a public health approach that tells us what to do in first line and second line. Second, the landscape is changing very quickly, because now I think that everybody is mature enough, and we see more and more companies getting agreements through the medicine patent pool and using different mechanisms in which drugs that were impossible to think about in very low income countries are more easily to be obtained. So I wouldn't say that we don't have any response for developing countries. We do have the public health approach from WHO, and again, it might happen that some drugs, like for instance TAF, would be first available in South Africa before it is in the US, due to the agreements with the generic companies. So I wouldn't be so pessimistic regarding this issue.
Great. Yes? Front microphone.
I'm Dr. Saple from Mumbai, India. We should start as soon as possible. That include primary HIV infection. In primary HIV infection, sometimes the CD4 count is very low. So we start at that level, or we should find out whether it's a primary infection or it becomes a chronic. We should wait.
I'm in favor of treating primary infection. Other comments, Mike?
Yeah, I think for a lot of reasons, you'd want to start as soon as you can. I don't think cure is necessarily the prime reason, even though that's been advocated and it's gone back and forth. But from the very, very first time when the virus starts to replicate and it's spreading, it's doing harm, and especially in that very first couple of days to weeks. And so the guidelines do make a comment about that, this updated one. I think the spirit of this is that you want to start as soon as possible during acute infection, and most people would start with a regimen they think is going to work, meaning like a boosted PI, and not wait for the resistance test to get a resistance test, but not necessarily wait for the results to come back before you actually start treatment. When the results come back, then you can modify your treatment based on the outcome of the resistance test, but as soon as you possibly can. And I wouldn't go as far as say it's a medical emergency, but there is some urgency around it, because you have a chance to really preserve a lot of the immune system function and keep a lot of the tissues from being destroyed by the ongoing acute infection syndrome.
Thank you very much. Last question, Frank.
Frank Rain from Minneapolis. You've talked about FTC and 3GC as being interchangeable, but I'd like to make a weak case that M-tricytidine has some advantages over lamivudine. We all believe that Truvada is a little bit more potent than Epsicom, and we really don't know whether it's the FTC 3TC difference or the tenofovir-bacivir difference, or it may be the combination, because the 184B seems to do a little 184 seems to do a little more harm to the bacivir than to the tenofovir. But nevertheless, when Gilead changed its regimens from studying tenofovir 3TC to tenofovir FTC, they seem to do a little bit better. And we don't have that awkwardness about once a day versus twice a day when we're using lamivudine alone. So I'd like to make the case that emtricitabine is a little bit better and hear your comments on that.
Very quickly, Joe.
I agree that it's a little bit better. I think there are some data suggesting that you get less M184V. You have more confidence in the pharmacokinetics. And if everything was equal, I would choose emtricitabine for those reasons. I think that as lamivudine goes generic and gets cheaper, we may not always have that choice because the data are suggestive but not overwhelming. But if I am allowed to use emtricitabine, that would be the drug I would pick.